Thank you everybody for joining, and hopefully you'll learn a lot about our study, looking at the evaluation of Scotland's first and only managed alcohol programme. So, move the slide. Paranoid now.
Let's move.
Thank you. Okay, so just a bit of kind of a little statement just to say that this research is funded by the Scottish Government's Chief Scientist Office, who've had no role in the design, implementation, analysis, write-up and dissemination of the research, and also, to importantly, the evaluation has been conducted independently of Simon Community Scotland, who run the map. No conflicts of interest to declare, and Emma, Jess and I are part of a wider study team alongside the people that you can see on the screen. And we also obviously want to thank Simon Community Scotland for their ongoing support, yeah, thanks to that. And I can see that you're joining from the map on the big screen, so no pressure to us at all. So I'm just going to give a bit of background about why managed alcohol programs kind of are a thing, and also just tell you a little bit about the map before we go on to tell you about the research. So you probably all know about this, but just to kind of contextualise the study, people experiencing homelessness often use alcohol as a response to trauma, as a way of coping with difficult life circumstances. Quite often the only treatment options that are available are abstinence-based, and while they might work for some people, they're not always appropriate for this population for a range of reasons, and we don't have time really to go into the background in more detail. But these kind of reasons mean that harm reduction approaches are required. So managed alcohol programmes, or MAPs as we're going to call them for the duration of the study and the presentation, take a harm reduction approach and have been specifically designed for this group. So they are services where regular doses of alcohol are provided throughout the day alongside a range of other supports. So it could be things like housing, physical and mental health care, welfare and social connections. They were developed initially in Canada in the 1990s and since then have spread across the world, particularly kind of there's several in Europe, Ireland, Northern Ireland, Republic of Ireland, Canada, the US, and obviously now in Scotland. Much of the research has been in Canada because they've been running there the longest, and the evaluations there have shown that kind of really positive impacts for people. So there's been things like improvements in alcohol consumption levels, alcohol-related harms, the relationships that people have, and also reductions in things like emergency healthcare, contact with the police and with the criminal justice system. So Scotland's first managed alcohol programme opened in September 2021 and is run by the Simon Community. It has capacity for up to 10 men. Each of them have their own ensuite rooms and have access to a wide range of services and activities, as well as, importantly, the regular provision of alcohol throughout the day. So we were funded in December 2023 to evaluate the service, as well as to conduct research that would inform future service delivery. So say another service in Scotland wants to set up a map, what do they need to know? And also future research, because actually most of the research in this area has been done in Canada, so we need to know whether that's kind of appropriate in this country. The study will run until the end of March 2026, so these are very kind of initial findings and might not be exactly what we report right at the end, but it's just, yeah, we're at the stage where we thought we'd share some of our initial findings for people. So today we're going to talk about the 4 work packages in the study. I'm going to cover the first one, Emma will cover the 2 middle ones, and Jess will talk about work package 4. So our first work package was what we call a realist review of international evidence to identify what works for whom and in what circumstances. And a realist review is a type of literature review which is a method for studying complex interventions in response to the perceived limitations of conventional systematic review methodology. So it involves the identification of contexts, mechanisms and outcomes for individual programmes in order to explain the differences between them. So realist reviews aim to look at the available evidence on a particular intervention, so in this case MAPS, and look at the context, so the settings, the kind of wider context of where things are, the mechanisms, so what are the kind of behavioural processes, and then the outcomes, what happens as a result of these interventions. With the assumptions that outcomes of the interventions are directly caused by these underlying mechanisms which have been activated in particular contexts. We don't have a huge amount of time to talk about what realist reviews are, but if you're interested and want to know more, please do get in touch. So we followed the 5 steps of realist reviews and we developed 24 initial programme theories. So these are things that we think might be the kind of reasons why maps might work and the kind of circumstances in which they might work. So we developed these, then we looked at the overall kind of international evidence base out of 60 sources, and we then synthesised it and developed, we brought the kind of 24 theories into 11 final programme theories. And I'm going to talk about 5 of these today because there's not enough time to talk about them all. So this is just if you think about all the kind of evidence of maps, and these are kind of the things that might be why these services would work for people. So the first programme theory is about the kind of background. So they're needed because services are unsuitable for people, so they can't access the support they need, and there's often the expectation of abstinence. So the evidence that we reviewed showed that alcohol policy in many countries, particularly North America, where there's much more evidence, that's followed a kind of traditionally moderation or abstinence-based approach. So homelessness shelters and other services require abstinence, and housing is contingent on abstinence and is based on the assumption that people would comply with treatment for mental health and substance use problems. And an abstinence-based approach to housing has been criticised because of a lack of understanding of the mechanisms behind behaviour change and a failure to respond to the additional needs of people who are experiencing both homelessness and alcohol dependence. So this means that people might avoid attending shelters altogether, or they might drink all their alcohol before they go into their shelter because they aren't allowed to drink there, which can obviously result in a range of negative outcomes, violence, injury, even death. And we know there's a lack of alcohol harm reduction approaches for this approach. Most harm reduction things focus on kind of population-based strategies, for example, minimum unit pricing. So services like MAPS, which have a really key harm reduction ethos, are really essential for this population, for whom other services are unlikely to exist and mean that people fall through the cracks of services. So our second programme theory is just explaining why MAPS might work for people. So they offer high engagement because they offer housing, help, and other things and don't require abstinence. So they offer a response to the needs of people experiencing homelessness and alcohol dependence who aren't able to become abstinent for whatever reason. They offer controlled drinking with alcohol of a known quality and quantity at regular intervals throughout the day. So moderate drinking is therefore seen as the more obtainable goal for those who experience alcohol dependence and for whom abstinence isn't achievable or is not wanted. And the documents in our review showed that there's a wide variation in how individual MAPs operate. So some are residential services, most of them are, and others are drop-ins, and there can be variation within and between these models. Some can provide food, they might be run by peers, so people with lived experience. Some provide housing, and most will provide some sort of activity support. And they've often been described as places of safety, stability, and belonging. And it looks like the key kind of part of a map is the permanent housing and the sense of a home on how maps kind of work. Our third programme theory explains why maps might work for some but don't actually work for everybody. So they might be suitable for some people, but they don't work. People don't fit within the service and kind of it works for them. So they might be the last treatment option available, but may still be unsuitable for a range of reasons. And it showed, the documents that we reviewed showed that some people were dissatisfied with the timings of alcohol administration. So in some places, they're very rigid and would be at very set times throughout the day with limited flexibility. They might be dissatisfied with things like the strength or amount of alcohol, if the map only provides a certain type of alcohol, or the lack of choice, which often leads to people drinking outside of the map. Some maps require participants to be on site, so in the map for 90 minutes before they get serving, and if they're not, then they don't get their alcohol at that point, and they would have to wait till the next pour. Others might operate room and person searches to discourage people from bringing alcohol back in. People need to meet particular eligibility criteria set by the individual map, and they have to be willing and kind of wanting, motivated to join the programme, and these criteria can vary between services. And often strict criteria and rules are in place to attempt to discourage outside drinking, which can lead to people drinking more alcohol, resulting in acute and chronic health harms. There's also evidence that participants in MAPs with stricter rules around outside drinking do report lower rates of total and, in case of Canada, non-beverage alcohol consumption compared to those with less effective policies. So while effective rules and regulations with clear eligibility criteria are vital, they need to align with people's needs in order for them to engage fully with the service. Our fourth programme theory looks at how, prior to joining a MAP, people would talk about the ongoing struggle to find money for alcohol, to obtain alcohol, either beverage or non-beverage alcohol, or to attempt to ration it or store it in order to prevent withdrawal. And for many people, this focus on alcohol was all-consuming. So the managed and reliable doses of alcohol provided by MAPs allow people to no longer be in this kind of survival mode, allowing them to think about other things, to do other things, to be involved in a range of activities. And often MAPs will provide a wide range of activities. There might be sports, arts and crafts, music, outside activities, visits places, particularly in Canada, where there are maps specifically for Indigenous communities. There might be cultural activities, and these are kind of in place to help things like preventing boredom and disconnection. So overall, the regular provision of alcohol within MAPs enables people to engage with other activities because they're not preoccupied with searching for alcohol. The alcohol's there and it's provided to them regularly. And then their final programme theory to discuss today is how that they can reduce interactions with very costly services. So before entering a MAP, many participants have reported having regular interactions with emergency healthcare, with criminal justice service. And one study that was in our review noted that frontline service providers often describe these people as frequent flyers. So these individuals often cycle between risky drinking, intoxication, and emergency admissions. And when people enter a MAP, the stabilisation of alcohol use results in fewer alcohol-related harms, such as intoxication, disorderly behaviour, and injuries, and can lead to a significant reduction in emergency service use, sometimes by over 50%. While some healthcare interactions like ambulance call-outs and emergency department or A&E attendances and hospital admissions can reduce in a MAP, others, like primary care, might increase in a good way because people are seeking preventative healthcare much more regularly, and there'll be clinical input provided to people. There's also evidence that hospital-based MAPs have been successful in encouraging participants to stay in hospital for treatment because they don't feel like they have to leave the hospital to get alcohol. And staff who've been involved in these studies feel that the benefits outweigh the risks. So MAPs can reduce the likelihood of someone attending emergency departments or having contact with the police because regular alcohol in a MAP means that they're less likely to be intoxicated or drinking in a risky way in public. And obviously these can have cost savings when people are not using these very expensive services. So I'm now going to pass on to Emma, who's going to talk about work package 2, then 3. So over to you, Emma.
Great, thank you so much. That's lovely, Hannah, to have that kind of introduction to what the MAP is. So I'm going to talk a little bit about the sort of quantitative exploration of the MAP. And we did present a longer paper on this at the KBS conference that we're hoping to get published fairly soon. So hopefully we'll have more kind of insights if anyone's interested in that. Can I have the next slide, please, Hannah? So the aim of this work package was really to understand some of the changes over time, as well as the feasibility of conducting these sort of measures longitudinally and the recruitment and retention in order to inform a future outcomes-focused trial. So we carried out questionnaires with the MAP residents and with 10 people recruited from 2 services in Glasgow. And we matched these locally matched controls as closely as possible on age, ethnicity, and levels of drinking. I think it's important to note, if we have any statisticians among us, that because the map is only a 10-bed service, we have obviously 10 participants in the map, which means it's not really going to be kind of highly powered enough to show any sort of significant differences. But we did hope that it would start to sort of show us some information about the differences between maps and controls, but also just sort of to, as I said, to show us the feasibility of doing these questionnaires with our participants. So we did a range of questionnaires, which I'll go on to explain on the next slide, at four time points. So baseline when we recruited people, and then 3 months, 6 months, and 12 months later. If I could have the next slide, please, Hannah. So I know this is very small writing, but just to kind of give you an overview that we gave people quite a barrage of questionnaires at each time point. So we had questionnaires on alcohol dependence, on drug use, on alcohol consumption, mental health, quality of life, health status, and social support. And all of these questionnaires were done face-to-face with a researcher, myself, verbally going through all the questions with the participants. And participants received a £30 Love to Shop voucher after the completion of each time point, just as really a thank you for their time in coming to complete the questionnaires. I could just go on to the next slide, Hannah. Thanks. So this is just sort of an overview of the participants that we recruited, or that we did questionnaires with at each time point. So as expected, people did sort of drop in and out of the data collection. Our protocol stated that if somebody missed a time point, they were still eligible for the next one. So unless somebody had actually said they no longer wanted to take part in the study, we did recontact them at the next time point. So as you can see, we did have, especially with the controls, times where people kind of dropped in, but then dropped out, then came back in again at a later time point. I think it is probably quite important to say that it did take a lot of researcher time to conduct the questionnaires and to contact people for questionnaires, particularly with the control participants. So it was a lot of my time kind of going to services and meeting people in the city centre in Glasgow. And yeah, so it was quite researcher intensive, even just for these 20 people that we had. Go on to the next slide, please. So in terms of some of our kind of outcomes that we saw, we did actually manage to match our residents and controls pretty well. They were actually ended up being very well matched for ethnicity, age, and years of drinking at baseline. All our participants identified as white. Some were white Scottish, some white British, but all white and all male, obviously because the map only takes men at the moment. So at baseline, our controls reported a higher average daily units than MAP participants, but not all our controls drank daily. Everyone in the MAP reported drinking daily, as expected, because obviously they're in a managed alcohol program. So you hope actually that they will be drinking daily. Whereas some of our controls had kind of really high units and then maybe not so many the next day, or some periods of abstinence. We did ask people about their drug use. For the majority, they either took no drugs or cannabis with maybe occasional cocaine use, but 2 of our control participants used drugs more regularly. And we asked people about their drug use at every time point, and people's drug use did remain fairly consistent throughout the study with what kind of they personally were using. So the audit scores for alcohol dependence show that the average audit scores were similar across time points for both groups. And both our MAP and control participants suggested moderate severe dependence in the audit and in the SADQ scores. If I could go on to the next one, please. So our PHQ-9, which looks at depression, and the GAD-7, which looks at anxiety scores, were similar at baseline, 3 months and 6 months. What's quite interesting is that our controls showed lower scores at 12 months. And I'll go on a bit later to talk about some of the reasons why we think that might be. But again, as I said, it isn't sort of massively highly powered, but it was an interesting outcome that we found. Anna, if I could go on to the next one. So ICECAP A looks at quality of life and capability values. And again, it shows that our map and control participants were actually broadly similar at baseline 3 months and 6 months. But again, at 12 months, our control participants suggested that they maybe had a higher self-efficacy than map participants. So it looks at kind of how confident people feel about being able to achieve the things that they want to. We also looked at the EQ5D3L, which is a health status scores, and we've only presented here the VAS scores, which are kind of a numerical value of health status. And score again, this kind of goes up and down. So our scores were similar at baseline and 3 months between the map and controls. At 6 months, the map participant scores were slightly higher than control participants, and at 12 months, the control participant scores were slightly higher than map participants. We don't really have any particularly good reason why that might be. People just kind of go up and down with their kind of health status at that time. Can I go on to the next one, please, Hannah? So the important people in drugs and alcohol was quite interesting, particularly in light of the qualitative thing that I'm going to go on and talk about in a minute. So we used an adaptive version of a questionnaire called the Important People in Drugs and Alcohol Survey, and we adapted it to concentrate on alcohol rather than drugs. And the IPDA essentially asks participants about important people in their lives. So ask about people that they have seen regularly, that they're in contact with, who support them. And interestingly, participants in both groups really struggled to identify any close friends. Their support networks were mainly staff in the services, particularly in the MAP, and other residents, again in the MAP, with some reporting having family members who supported them. So one control participant didn't have anyone at all in their social network, couldn't identify kind of anyone that they saw regularly. And others identified sort of friends and supporters. So nobody in the MAP identified a friend who was outside the managed alcohol program, but they did have lots of friends and support with other residents in the MAP. Control participants did have, as I say, a few more kind of friends outside maybe the hostel in which they were living. And I will go on a little bit more to talk about that with the qualitative stuff. Just to go on to the next one, thank you. It's just overall, obviously, that's I know that's a bit of a whistle stop tour through our quantitative things, but overall retention, so recruitment was successful for both groups. We ended up with 10 people from the MAP and our 10 matched controls. Retention was more challenging, as I said, particularly amongst the control groups. They were fairly well matched. Both our MAP and control participants presented with high levels of alcohol dependence and poor mental and physical health and long histories of alcohol use at baseline. So we did find that our results suggested that sort of the more structured provision of alcohol in the MAP provides more stable consumption patterns. However, MAP participants' average consumption increased a little bit at 6 and 12 months, whereas some of our control participants reported reducing their consumption or becoming abstinent towards the end of our study time. So as I mentioned before, we did have a couple of questionnaires where it looked like our control participants were had sort of improved scores at the 12 months thing. We suspect this might be due to the fact that attrition, so where we've kind of lost participants, which we did more in the control group, can be caused by things like housing instability, people going to prison, and poor health. So we suspect that potentially what has happened is that in our control group, we've lost some of our more vulnerable participants at the 12-month period. And therefore, the ones that have kind of remained with us and able to do the questionnaires are showing slightly better scores and slightly more self-efficacy and better physical health. It was interesting, although all our questionnaires were standardized questionnaires, which have been very well tested in many groups. A lot of our participants struggled to answer certain questions. For example, in the SADQ, it asks people to imagine a period of sobriety, and quite a few of our participants struggled with those kind of questions because they hadn't had a period of sobriety for a long time. If I can go on to the next one. Thank you, Hannah. So I'm just going to go on a little bit and talk about our qualitative exploration of the map. So this is our work package 3. And what we did was we incorporated visual and creative data methods. So we used photo elicitation and semi-structured interviews with the map residents to explore their experiences of the map. If I go on to the next one, please, Hannah. So we worked with an organisation called Photo Voice, and Photo Voice sort of specialised in doing photo elicitation with communities, and they came up to the map to do some training with the residents on photography, for example, how to use cameras, taking different photos, etc. And so all of the residents in the map were invited to take part in these workshops, and at the time of our first workshops, there was only 8 participants in the map at that time. We then used semi-structured interviews with each map resident in order to discuss their meaning of the photographs, and also what their kind of life was like in the map, hobbies and interests, and future plans from when they, if they decided that they ever wanted to move on. I could go on to the next slide, please. So as part of our funding, we provided residents with cameras, and we also had 2 extra cameras for sort of staff to have in the office at the map. The cameras that we gave to the residents were their cameras to keep and to do what they want with, and they really engaged with photography, and the staff in the map are continuing to support them. So they're now taking their own photographs kind of outside our workshops that we provided. I can have the next one, please, Hannah. So as I said, we did semi-structured interviews with the map residents, those that wanted to take part in interviews. So most of the residents completed more than 1 interview, and 1 resident completed 3 interviews. We roughly broke the interviews down into what life was like before they came to the map and how they ended up coming to the map, and then what the life in the map itself was like and kind of hopes for the future. So we did semi-structured interviews, they were audio recorded, and again, they received a £30 Love to Shop voucher for each interview. So I'm going to go on to talk a little bit about some of the findings from the interviews. As I said, these are very initial findings. However, when we did the photo elicitation work, all of the residents also provided quotes to go alongside their photos. So what I'm going to show you today is, although I'm going to talk kind of roughly about the interviews, I'm actually going to show you the photos and the quotes, or some of the photos and quotes that the residents were happy to have shared with a kind of wider audience. So if I can go, thank you, Hannah. So the men talked about their lives before alcohol and their journey towards alcohol dependence. And for some, this was due to quite a traumatic event maybe in their life. And for others, it was quite a gradual process towards alcohol dependence. Most of the men that we interviewed had grown up in and around Glasgow, and a lot described kind of a very multi-generational norm of quite heavy drinking, sort of growing up in households where parents and relatives and friends also drank quite heavily. Many of the men described previous attempts at rehab and either attempts at abstinence that were either unwanted or that they were not able to manage long term. All had been unstably housed, whether that's in hostels or sleeping rough or with own tenancies that they weren't able to manage due to their alcohol use. And they discussed the impact that it had on their families, which was obviously quite a big impact. Many had lost jobs, for example, due to their alcohol use, or kind of moved around areas as well. I can have the next one, please, Hannah. So they described the map as a really safe and stable home environment. It's very small and quiet and a very nice atmosphere compared to a lot of the much bigger hostels. Many of them said the map wasn't very well known, even within Glasgow when they sort of first came. And I know that the map, over the last couple of years has been doing a lot more work, sort of making themselves known to care managers and things throughout Glasgow. But most of the men had ended up here almost quite by chance through maybe support workers or addiction nurses or care managers who had happened to hear about the map and thought that they might be a suitable candidate for it. It is quite a lengthy process to get into the map with kind of various questionnaires and health tests and things. And some men reported being quite reluctant at first, even though the hostel that they were in was very large and chaotic. That was what was familiar to them. So it was quite a big change to come to the map. Many had experienced previous trauma, as I said, especially deaths of family members and friends, and hadn't been able to access much help previously due to their drinking. So not a lot of things like counselling, for example. I could have the next one, please, Anne. So the men go into the office to get their pour, as it's known, so their doses of alcohol. And from the interviews and my own observations of being in the map quite a lot is that the pours are actually a really good way of putting somebody in front of a staff member multiple times a day. And the men describe this as vastly different to previous hostels and supported accommodation that they had been in, where staff tend to be in the office and they don't see them very much. What they really described about the map was the engagement with the staff, who they ask them about their food and about shopping, check if they've taken medication, check if they've got upcoming appointments and things like that. So although they are going for these regular doses of alcohol, it actually is really a way of also interacting with the staff kind of multiple times a day. And just the next one, please, Hannah. So just the last bit that I'm going to sort of say about our qualitative work before I pass on to Jess is that many of the men in the map had families, and being in the map had allowed the men to kind of reconnect with families and have some sort of stability. As I said earlier, not many of them mentioned having current friends outside the map, which is obviously something we found in our quantitative data collection. However, this may be, in some cases, a bit deliberate. Quite a lot of the men describe previous problems about maybe being put back into or being put into hostels in familiar areas with people that they knew who were also drinking quite heavily. So it was then kind of hard to distance themselves from that kind of life. So this may be a deliberate distancing, but many didn't have a lot of ongoing connections outside the map, for example, support groups and things. So they have talked about it being quite daunting if they ever wanted to leave the map and go back into their own tenancy or their own home, is that they obviously will be leaving a group of residents and staff that they now know very well and are very comfortable with. And I'm now going to pass on to Jess, who's going to talk a bit more about the qualitative exploration of the map around sort of stakeholders and staff as well.
Thanks, Emma. So yeah, as Emma's mentioned, I'm going to talk about some findings from the qualitative interviews we completed with both MAP staff and external stakeholders on their views and experiences of the MAP service. So to start off with, I'll talk about the findings from our interviews with MAP staff. So we completed some semi-structured interviews with 11 MAP staff in total, and also one social work student who was on placement there in the service while we were doing the evaluation. Next slide, please, Hannah. I'm not going to speak through each of these quotes as some of them are quite long, but please feel free to read these as I go. So staff talked about the range of support, both informal and formal, provided to residents and the type of work that they're trying to do with them. So this included managing their alcohol and reducing harm, also increasing access to different forms of healthcare and improving health overall. Also improving relationships with families and other external relationships they might have, ensuring residents feel cared for and supported, and also helping to improve their own self-esteem of the residents. Next slide, please, Hannah. Staff talked at length about the key part of the MAP being the management of the residents' alcohol use. So having flexibility in alcohol agreements and plans was seen as both a positive and a negative by staff. They thought that it allowed people to make changes that suited them when they needed to, but some staff felt that residents were potentially changing this too often in order to get more alcohol. Staff had a good understanding of the physical and psychological alcohol cravings and the triggers and how best to manage these. And they talked about the pros and cons of people drinking in their room versus if there was communal drinking, as at the moment in the MAP, the pours have to be taken and drank in each of the residents' own rooms. But there was an awareness that communal drinking was happening outside of the MAP. and drinking outside of their pores was a particular challenge for the staff, both practically because, you know, if the resident was clearly intoxicated, they felt they couldn't withhold alcohol, and also morally asking the question, is it ethical to give alcohol to somebody when they are drunk and at risk of harm / potentially worsening their health? Next slide, please, Hannah. Staff talked about the importance of the map being the resident's home, which Emma has mentioned as well, and whilst recognising this as a service with its own rules and boundaries, staff wanted to make sure it felt safe and homely, but also sometimes felt conflicted when they weren't able to share information about someone, and this might be potentially if somebody had been taken into hospital or was removed from the map and they weren't able to explain to other residents why this might be. And also some conflicting feelings about entering people's own rooms as that is their own, you know, private space. There's also a sense from staff that some individuals may potentially become institutionalised and may rely too heavily on staff. This could be in terms of keeping their own spaces clean in their rooms, money management, personal care, such as, you know, overall well-being and personal hygiene and things like this. Next slide, please, Hannah. So now moving on to the external stakeholders who we also completed qualitative interviews with. And as Hannah and Emma have mentioned, this is quite early on in our analysis, so it's still underway. So there might be some changes between now and any final publications we have, but still wanted to share some initial findings. So we conducted interviews with 38 external stakeholders who came from a range of contexts. So that included 3 family members of MAP residents, and I'll talk about their findings later down the line. And also former MAP staff, 5 control group participants, some representatives from Simon Community itself, NHS staff, including hepatologists, addiction psychiatrists and nurses. So we spoke to quite a range of different people, all who had kind of varying degrees of interactions with the MAP. So some people having direct contact and interactions with the service itself, and others who have had an awareness of the service in and around Glasgow, potentially referred in, etc. So similarly to our other qualitative interviews, all the transcripts were coded thematically, which resulted in several different themes. And the first of these kind of related to the effectiveness of the MAP in reducing alcohol-related harms. So stakeholders spoke of the reduction in alcohol intake, with some MAP residents switching to lesser strength alcohol, such as moving from drinking vodka to beer. There had been fewer blackouts and emergency interventions, with a decline in incidents requiring ambulance or police intervention, indicating improved safety and stability for residents. The kind of stable living environment that the MAP offered kind of provided a predictability of routines, which kind of amplified that feeling of security and enabling residents to manage their alcohol in a more controlled and safe manner. However, the stakeholders did speak to the fact that some residents are still drinking outside their pores, as was mentioned by staff, or potentially consume alcohol out in the wider community, indicating that there might be some mixed findings around whether alcohol intake has decreased substantially for some of the MAP residents. In terms of wider service availability, participants stated that currently there are very few tailored interventions for people facing both homelessness and alcohol dependence, making MAPs a welcome addition to the existing service availability in Scotland. Participants viewed the design of the service as welcoming, modern and high spec, with the MAP being viewed as a nice place to be. And this was an important factor relating to the success of the service, as people were actually wanting to be there. However, the stakeholders did recognise it as a small-scale service with only 10 beds, leading to some of them describing it as a drop in the ocean compared to the scale of need. Participants also viewed the need for wider engagement with referrers, promoting the service with healthcare providers, social workers and other homelessness services to increase awareness and acceptance of the model. Initially, there might have been some hesitancy with some referrers, potentially due to traditional abstinence-focused beliefs. And so therefore some participants expressed there might still need to be further education and open conversations about the benefits of harm reduction approaches such as MAPs. Finally, stakeholders discussed some considerations for potential future implementation and expansion of MAPs across Scotland. It is clear that the success of a MAP is influenced by local needs, policies and service landscapes, and therefore future implementation must consider community infrastructure and healthcare and local service accessibility to ensure MAPs are well integrated into existing support systems. The current MAP is only available to men, so participants raised important points about how MAPs could be adapted for women and or gender neutral individuals. Future maps should explore safe, tailored environments for women and different genders, given they often face different vulnerabilities. Stakeholders also discussed the idea of maps in more rural areas as well. So given the current map is in Glasgow, they discussed what considerations would be needed in terms of staffing, transport and healthcare access. Participants also raised the point of how do we measure a successful map? So since the maps are resource intensive, some participants stated that there needs to be signs of some form of progression by map residents. So there should be, signs of residents striving to move back towards independent living with alcohol use at a manageable level and not remaining in the map indefinitely. Finally, the idea of completing a cost-benefit analysis of the current map was raised by some stakeholders. And while this isn't a part of the current evaluation, these stakeholders thought it might help make the case for future maps and ongoing funding for them in Scotland. But as I say, that isn't part of anything we've looked into and is a little bit difficult given the numbers that we have in the map right now. So moving on to family members' perspectives, they talked a lot about how residents ended up in the map and their journey to getting there and the experiences that they've had. They talked about positive impressions of the map, but a lack of information about what it actually involves and what it's like for the residents once we're there, and even what's happening with the residents too. Some were a bit sceptical about the map at first, as they thought residents would just be drunk all the time, but perceptions did slightly change and participants believe the map is good in terms of connecting residents with healthcare, going to appointments, money management, sleeping better, building confidence, and also accessing counselling and building better relationships with themselves as family members. They see the residents as being safe, they're eating better, and also, as I've mentioned already, kind of having improved overall well-being, better personal hygiene and looking after themselves. Family members also viewed the map staff as friendly towards the residents, and there was quite good relationships between them as well. However, they did raise some issues in terms of potential instances of residents not getting on with each other, and that was potentially due to lots of different experiences in one place, different personalities and different ages. It can take some residents some time to settle in and get used to hanging around with different people who they might not be used to being around, and potentially encouraging bad behaviour, whether that might be drinking outside of pores or more negative behaviours. The family members are really keen that there needed to be effort for the residents to be doing different things and not just drinking in the map. They need to be motivated and engaged in the other activities. And finally, just a little bit on our control participants. They weren't really sure of the map and whether they'd like it. They weren't sure if it was another version of a residential rehab treatment, and they weren't sure about the kind of isolated drinking which is needed in the map, where people drink in their own rooms and provide the social side of drinking. So that's everything I was going to say. So I'm now going to hand back to Hannah for some concluding comments, and sorry about the Zoom bomber.
Just shared to the final screen, so hopefully people can see that and you'll get the final points and where we're going to be, what's coming next. I'll do it so quickly that the person can't damage it. So hopefully you can see just the final slide. So this is just kind of some concluding remarks. Maps are required in context where alcohol harm reduction is limited, but obviously not always suitable for everybody, and can be beneficial in reducing interactions with a range of emergency services, and housing is obviously a very important element. It looks like the structured provision within the map might support more stable alcohol consumption patterns, but it might fluctuate. And obviously this study is probably too limited to go into that into more detail. So future research would need to look at this. Recruitment was successful, but retention challenging. And we know that from other studies in this field. It's difficult to retain people, especially things like having mobile phones can make it a challenge. The qualitative exploration showed that maps are viewed positively by people who are living there, by staff and a range of other stakeholders, and the map is seen as a stable, safe home environment. Can increase interactions with various forms of support, but unfortunately it doesn't seem to be very well known at the moment, which can affect referrals, although some of our interviews were done quite a while ago, so I think that's probably increased. Future map developments in other areas and with other population groups would be welcome, and maps are resource intensive and sustainability really needs to be considered from the outset. So just one final slide to see where we're at with everything. So our Realist review paper that I presented is currently in review, and our quantitative exploration, or package 2, will be submitted very shortly. We're continuing to do data analysis for the rest, and we're going to be producing a best practice manual for organisations who want to set up a map that will really explore kind of what's a successful map, how does it look, what do you need to think about. We will be running a dissemination event and photography exhibition in March 2026, so if you are interested, please let us know, and there'll be other dissemination planned between now and the end of the study next year. If you'd like more information, please do email me. Thanks.
There's a few things that have come up. Well, one of them, which I think you covered later on though, but I think is interesting, and you could maybe talk about it in a bit more detail, is about how you actually kept engagement going with the people who you had in the control groups, or the control group, because obviously that is a very I guess, flexible kind of population, and maybe a difficult one to work with. So Emma, perhaps that's one for you to talk about how you actually managed that process and how successful it was.
Yeah, so I think that was quite an interesting point. So we recruited from 2 services in Glasgow. So one was a residential kind of hostel, and that was a little bit easier. So 5 of the men were recruited from there. That was a little bit easier in that people did tend to stay resident there, and the staff were very helpful. We would go along and the staff were very helpful in contacting people. They kind of have individual sort of rooms within the hostel, but were quite helpful at sort of helping, sort of gatekeeping that and helping us with data collection. The other 5 men were recruited from who kind of had been in like a detox. And so they were quite difficult because they then, after their detox ended, kind of scattered to all the four corners of Glasgow, which, so we had people kind of living in their own tenancies and people who had then moved on to other hostels. Yeah, it was tricky. So a couple of men were happy to come and meet me in the centre of Glasgow. So I'd meet them in McDonald's or somewhere like that. Others, there was a couple that we kind of lost contact with. We did contact them at every time point. One sort of declined, although we had contact details for them. A couple I managed to track down to another hostel in Glasgow, and it really was a case of just turning up kind of multiple times to see if they were in. That hostel does feed people, which is quite useful, because if I went there kind of around afternoon, sort of like evening meal time, they tended to be kind of in the hostel. So that was helpful. But yeah, it was very intensive, I would say, to kind of keep in contact with people. And especially this population tends to change mobile phone numbers very frequently. So that was, although we had mobile phone numbers for people, that wasn't always that kind of helpful in keeping in contact with people.
Yeah. Yeah, I guess it'd be very particular challenges. So yeah, that's interesting. Another question, possibly that you might be able to answer, is from Jenny PC, which is why do you think that alcohol consumption for people in the map increased at the 6 and 12-month marks versus the control group?
Yeah, so I think that's interesting. It's something we reflect on a bit more in our paper that we're going to publish. So I think there's 2 reasons really. One is with only 10 people, and especially at that time point where I've not actually got my slide in front of me, but I think we maybe only had 6 or 7 people. So some of it's just a bit of an average issue. People had dropped out, and we maybe had someone who was either drinking a bit more or was perhaps drinking a bit more at that time point, or we'd lost a few people that were drinking less. So kind of it looks like kind of the numbers have gone up. I think that was certainly the case for the control. As we mentioned, we have some idea that the people we retained in the control were the ones who were kind of more stable and possibly drinking less. I think as well there is a potential, so Jess mentioned that some of the men in the map do drink outside their pores. And so although we have the map data, a lot of the questionnaires were self-reported alcohol consumption. So we did compare it to what we knew the map were giving people. So I do wonder whether there's a slight, they knew me a lot better by that point, and whether people were more willing to be more open with me about the alcohol that they were drinking outside their pores. So that could be another reason why it's kind of gone up slightly.
Right. Okay, thank you, Emma. Emma Williamson, you've got your hand up. would you like to ask a question? Is it related to that, or would you like to ask a question? We'll just try and
It
unmute you. Yeah.
was a separate question, actually, and if that's okay. I didn't know whether you were taking them just from the chat, so I've just put a really long message in the chat, but I can probably reiterate. Nice to see you guys. I'm really passionate about maps, as Hannah knows. I've dragged her down to London to try and talk to our commissioners at different times to try and get funding elsewhere. I'm really excited to see the findings of this come through. I was just interested if the literature or any of your work with the quantitative studies is looking at subgroups of drinking patterns, because I really feel that anecdotally there could be a real benefit in groups that binge all of their money and payday and then have sudden cliff edges with abstinence, and they're a really risky population for us, whereas maybe higher consumption but more steady alcohol use might be less risky in some ways, or less implicated for a map. And I just wondered whether that was something you were going to look at. Obviously it would need larger sample sizes, or whether the literature talks about those types of subgroup drinking patterns. Yeah.
Is there anyone who could answer that? Hannah?
I was going to say, Emma, to you. I think we've reflected on this a bit in our paper, where we had looked at, because we didn't have much time today, but we have kind of split it into like the people who stayed, who we collected data for the whole time, and then the people who we've only collected data for like once, and compared those. But I think, as we've said, there's not enough evidence. There's not enough participants in this study to really look at that. And I actually don't think there's been quite a lot of qualitative work done on maps, but quite limited quantitative. So from memory, I don't think this has been looked at, but I think it's really, really important thing, especially kind of for future studies, looking at in terms of kind of eligibility and criteria for services and things.
Yeah, and I think there was quite a bit, I would say, in the Realist review papers, but more around sort of non-beverage alcohol use, which isn't so much of an issue for us in Glasgow as it is in kind of Canada. But yeah, that I think talked about those kind of subgroups of people who move on to non-beverage alcohol because they are using up maybe their money quite early on after payday and things.
Yeah. Different profiles, actually, and I think clumping people together, you might lose some of the impact or effectiveness of the interventions. Yeah, it would be interesting to see how things progress. Thank you so much, though, for your presentation.
Thank you. Alistair, you've got your hand up. We'll just unmute you.
Thanks very much. I can't come on the videos, but I am here. I mean, first of all, it's such a difficult group to work with, so fantastically well done with all your studies. I guess I had a few sort of a methods type questions in relation to the quantitative stuff. You know, I'd be very interested in the ones who drop out from the MAP group. I mean, are these people who have left the program or are still in the program but don't want to help? And are they different? Are they dead? You know, and a sort of related question is that, you know, when you selected your your clients, participants, presumably people have been in the MAP for varying lengths of time. You know, what the criteria had to have been in for a certain length of time to be stable before they were allowed to take part. You know, I'm just interested to know how you ran it. It's a great study. Well done.
So in terms of, I'll answer your last question first, and that's okay. So no, so it was open, although people had been in at varying lengths of time, because the MAP is such small numbers, it was open to anyone who was in the MAP when we were recruiting. And in fact, we did have a couple of men who joined kind of later on and were then recruited into the study. So I probably should have explained that before. So actually, a couple of people we didn't get 6 and 12 months for, because actually they hadn't been in the study long enough for us to do the 6 and 12 months for the end of our data collection date. And so, yeah, the data collection dates are slightly staggered, which we do kind of explain a bit more in our longer paper. And your other question about people leaving. So 3 men left during the study. So one went to another supported accommodation, one went to a hostel, and one went to their own home. the man who went to his own home declined to take part in further data collection with us. We would have done it probably over the phone with him if he'd wanted, but he declined to take part in further questionnaires. And the other two, we lost them just due to a lack of contact details. We didn't have kind of following addresses and things for them. So that was the kind of the three that had left.
Thanks.
Thank you. You may have all seen a question in the chat about access to sort of other services to do with alcohol harm reduction or alcohol use reduction, and there's one about testing liver function using FibroScans or other scanners. And Craig Bell, who I assume is connected to the service in Glasgow, has answered to say that there was access to liver function and FibroScans as part of the assessment process when people enter the map. And then this was carried out on an annual basis in terms of measuring health as well. So there's that bit of information there. And then there's some other questions about the service itself now. So things like how people get referred into the service, how long people may end up living in the map. I don't know if that's something that you as researchers can answer, or if there's anyone else from the Simon community here who'd be willing to answer those questions.
See
Hannah.
Peter right up at the screen, so I'm sure he's poised, ready.
Is Peter there? Brilliant. Thank you, Peter. Thank you. So Peter, once we've unmuted you, I'll introduce you. Thank you. Hi, so Peter is the manager of the Managed Alcohol Programme. So thank you very much for joining us today. I'm assuming that that wasn't all news to you, that was in the research findings, but you'll see we did have some questions in the chat about how the service runs and how you get referrals, how long people stay with you. I don't know if there's a couple of points like that that you might be able to quickly respond to, because we've only got a few more minutes now as well, so thank you.
Yeah, so the service is open 24/7, and the first time that the guys get the pours is 8 o'clock in the morning, and the last time they get the pour in the evening is 9:30 in the evening. Obviously, that can change depending. You know, somebody is getting into alcohol withdrawal, we would work with them with that. Referrals are made by care managers. Yep, and they go through a screening process. So that's getting the liver scan, bloods, physical health assessment, cognitive assessment, and that usually we try and get that done within the 1 day, and then it goes to our liver hepatologist, and they're very quick at getting back to us. So it's quite a quick turnaround. Then somebody would know obviously if they're suitable or not. Then obviously we would do a bit of motivational work with the individual as well.
Okay. And then how long would, is there an average length of time that people will stay with you in the map?
Yeah, longest is just over 3 years. The kind of a shortest we've got just now is about a year. So it's kind of a quite kind of a mid to long term. Yeah.
Yeah. Okay, thank you. And where is it that people move on to usually?
It varies. Yeah. Sometimes it's inpatient detox, then on to rehab. Sometimes we've had three of them went into our detox and then went into their own house. Sometimes they've left through choice. You know, sticking to the programme can be quite difficult for some of the men. Sometimes they've decided that it's not for them, or sometimes the harm reduction is not for them, and it's more abstinence with certain needs.
Yeah, okay. And then there's someone from Cardiff, I think it was, here as well, who said that they have a lot of polydrug use in similar services. Is that something that you come across or deal with, or does that mean that people can't come to the map?
Cocaine. Yeah, we're finding that there's a couple of men that's using periodically. They're using cocaine. Yeah. We've had men that's used illicit drugs pre-map, but once they've come into the map service, and I don't know if I'm sure the study will be showing that they've stopped using the street drugs as well. They've been reporting that as well. Yeah.
Yeah. So yeah, you'll have lots of different challenges that you'll have to deal with as you go along. So yeah. Well, thank you so much for filling in those gaps, Peter. That was really, really helpful. I really appreciate it. So thank you once again to everyone for coming today, but thank you especially to our speakers today for setting out really interesting findings that I think we'll all be able to learn from. So thank you.